The AMOS project, Adolescent Morbid Obesity Surgery project, started out as a joint project between Gothenburg and Stockholm, and then after a few years, Lund, Malmö also joined the project. This is, as an adult bariatric surgeon, this is the figure. These are the figures. I almost showing this always when I'm having a lecture to anybody about what I'm working with. That it tells just a story that it's a guy putting a dot in a diagram every half year from 1979 until 1997. It's an average Swedish person. Not. But he was here joining the Weight Watchers and having a weight, and he was struggling with this, and here he managed to come up to 100 kilograms in 1983, and then he dropped 15 kilograms, and then he went back to 100 kilograms, and then it was Weight Watchers again, 25 kilograms weight loss. And then he slided up a bit, and then there was an accident that he was into. And after 3 years, he was 105 kilograms after being 100 kilograms here. But in between, he was 75. And then he lost 15 kilograms again, and up and down you see it goes. And up here, you have a person being referred for bariatric surgery. And when you show this to a group of patients having a severe obesity problem, everybody sighed and said, "Have you stolen my curve?" Because everybody recognized that, and this is what we are fighting with. So we are not fighting obesity usually with people just not caring. They are struggling and they are losing weight, but they're regaining, as Carol told us. And the notion we had out here when they were referred and when they had the intervention, they said, many of them coming back, that there's one thing I regret nowadays. And what is that? That I didn't do it before. That's the simplicity of a surgeon saying that. But that's a fairly common comment when people say, I have waited too long to do this. So therefore we teamed up with pediatricians in Sweden, and again it was really brave of those, especially I must give a great credit to Claude, to dare to put your nose out there and say that could we use bariatric surgery for kids, adolescents. And as Thomas mentioned, the only randomized study been there is the longitudinal, or it was Billy saying, the Australian study. So there was sparse data in this, but we decided to do it in the way, because we, as you decided in the T-Labs, that we weren't in the position of doing a randomized trial, knowing that we didn't have the safety and efficacy data. It was very hard to talk people into an intervention which we knew relatively little about. So therefore we decided to have a prospective controlled non-randomized trial. So we aimed at recruiting parallel controls, as in the SOS study, where you decide to have surgery or not having surgery. I will come back to that, how it ended up. Stockholm, Gothenburg, and Malmö were the recruiting centers. Surgery at Sahlgrenska in Gothenburg, and I couldn't resist making the font a little bit better with Gothenburg there. Inclusion criteria was an age of 13 to 17 up to 18 at the time of inclusion. Regular BMI levels 40 plus in BMI without comorbidity and 35 plus with comorbidity. Failure on conservative treatments, of course you have tried everything else in the bucket. They should be mature in the skeleton to a tenor above 3. Exclusion criteria were monogenic obesity, which is and also syndrome obesity like Prader-Willis or all the names in this. obesity secondary to brain injury, severe or untreated psychiatric disease, or surgical or anesthetical contraindication. So the primary endpoint of the study is weight loss and weight stability, because that would be the, as we consider, the best surrogate markers for an outcome. But also equally important that we are looking at metabolic control, inflammation, anthropometry, eating patterns, quality of life. I see I have anthropometry and body composition, but also skeletal development. So the control groups were planned to be those not opting for surgery. But Claude, you called me after a while and said that we have a problem, and that we expected every fourth patient to have surgery, but after a while, when having surgery, you had a hard time to find controls. So we have to have another other approach in this. So we decided to go into the registry and contemporaneously identify those in Swedish registries having a high BMI, the closest we could get to those having surgery. And those were not it was not reported to them that they were in the registry. We were actually having the ethical permission to identify them, but not contact them until 5 years after surgery. And also we picked another surgical group, which are adults 35 to 45 years of age, having Roux-en-Y gastric bypass, actually under the same team, exactly in the same way. So we ended up with a cohort of 81, which had this spread in age. So they were normally 15, 16, 17, and 18. They had a mean age of 16.9 years. The intervention we used were decided to be gastric bypass, as we have a long tradition in Scandinavian bariatric surgery of using that, and it's been standardized in a way that we feel confident to deliver even to younger patients. And we haven't, I'm saying to patients sometimes that this gastric bypass is the Volvo V70 of the Swedish surgery, that it's the one that's been there for a long time, and it's durable, and we know that it actually works for a long time. So it's, but the features I want to point out with this surgery is that, a little bit in contrast to the US experience, we make no effort at all to make a limited stoma up here. We are making a wide open stoma. So we are, from a physiological point of view, thinking that it's much more important that the food is coming down to the bowel that, compared to that it's holding back, as Carl mentioned with the physiological considerations. And also we have we didn't close the mesenteric defect, and those who are familiar with bariatric surgery, you have heard about internal herniations. And at that point, we were aware that this was a problem, but we said that we didn't want to take another element of surgical, because we didn't have a safe technique of using that at that time. Psychosocial background I will leave to Kajsa, but it's a very scattered picture when you're looking at the psychosocial background in the population here. I will give you just repeat the data that we published in 2012 and try to stress some of this. That this is maybe what we expect over 2 years in non-surgical controls, because we were looking in the registries. We were not taking them in to actually measure them, but we looked what weight outcome was there in the Swedish registry, and so they gained weight. They lost a little bit during the first year, but then they gained again. But if you take adolescents having gastric bypass surgery and compare them to the real mature and well-behaving adults. So we had, you can see what's happening. They're almost like a carbon copy of each other. So it's, to me, this was a little bit of the physiological, what do you say? You just saw that it's probably dominating physiology, because if they should behave, our teenagers would not have done that. in order to lose weight. They lost from, as you can see now, Tom's data had a BMI of long over 50, but here they are around 45-ish. I just want to show the consistency of the weight loss, that this was a problem with the banding studies, that someone was going extremely good, and someone lost nothing, and someone gained weight, and there were numbers in between. But the bypass and the robustness of the physiology seems to deliver a type of consistent weight loss in patients after gastric bypass. What about the metabolic markers? We found, as you did, that there were improvements in fasting glucose and HbA1c. But what really stood out is the quite dramatic drop. Now we have another scale at that time. But this is fairly high levels of insulin going down to normal levels after 1 and 2 years. So insulin resistance obviously drops dramatically. But also seeing here that inflammation, I mentioned before that we see the white cell count, but also the CRP drops from around 7. And this is something you don't notice when you see the laboratory reports in adolescents, or in other morbidly obese patients, that they have some 8 or 9 or 12 in CRP. But if you look there, go and look there, you can see they are almost always increased in their CRP. So even adolescents had a CRP over the normal values, but they dropped to about 3 after 2 years. Lipids are going the same way, the triglycerides going right, and we actually had a drop in LDL, and we had an increase, this is fairly consistent in bypass series also from adults. And we had a significant decrease in systolic and diastolic blood pressure. Now I'm just mentioning from quality of life point of view the generic scale of measuring quality of life, and that is the SF-36, which is widely used in all types of conditions. And here we can see that from physical point of view, they were actually quite active still as teenagers, but they could improve as morbidly obese teenagers, but they improved in all qualities of physical health. And there was you have a composite score for physical health, and that was significantly improved over 2 years. But if you're looking with the generic score for mental health, which is vitality, social function, role emotional, and general mental health, they improved, but only in 2 out of 4 variables. In the composite score, they didn't improve. And this is what Kajsa will take further to us to discuss. What are the reality behind those pictures? From a quality of life point of view, Eva has put this together, and these are DEXA scans on a person that was 18 years of age. At that point, 192 kilograms. After 1 year, 134. After 2 years, 99. Somehow, if you put yourself in the position of being an employer and having these 4, or this one, coming into your office, do you want to hire him? There's something I think you see when you look at those pictures about the lungs, size of the lungs, the shape of the bone. Yeah. So what about talking about bone and different types of the body composition? What did they lose? Are we making them still obese? Are we just losing muscles? No, we are not. We can see that there's almost, especially in boys, there is an unproportional preservation of the lean tissue, which we have been seeing also in adults, that you can preserve the lean mass, especially in boys. But the dominating part of what you lose is body fat. If you're looking at bone over those 2 years, you can see that you have an increase in the BMC, which is expected, but that's nice to see that you continue increasing that. However, the density of the bone drops over the 2 years after surgery. And also the Z score for this. This is something that I think we have to discuss a little bit more in detail. I think there's an artifact in that which has been shown by the Kaplan group in Boston, that you have, it looks as you lose more bone in the BMD in the beginning as you lose so much weight, so you get an artifact of as it looks so. But what we also see is that they are coming from an extremely high level. O here would be the norm for the age. So they are approaching a normal skeleton for their age. Adverse events, the flip side of the coin. Fortunately, we had relatively few severe perioperative complications, which was 2 blood transfusions postoperatively, and 1 coming back with a deep infection, which was treated by antibiotics, making it 3.7% in more severe complications. During first 2 years, however, there were a substantial amount of adverse events that were related to surgery, which was 13.5%, having some type of surgical procedure done, which was either a laparoscopy fixing an internal hernia, which was what I was talking about before with those mesenteric windows where the bowel can get trapped. Adhesions in 1 patient, and 5 of them having cholecystectomies. At that point, we didn't use ursodeoxycholic acid, but so we realized that even teenagers develop gallstones. Here we have drug abuse, and we have 6% there, and psychiatric issues is 7%. We did an analysis of that, and that's fairly high, of course. But fortunately, at least, we could not see that patients that didn't have problems at baseline developed de novo severe psychiatric issues. And even we found out eventually that some of the, at least some, I think most of those in the drug abuse group had problems at baseline that was hidden in order to get surgery. Poor compliance of supplementation, Eva, you will talk more about that, but also developing excessive skin. I think I leave that for a moment, but we have had a paper on that. Just to see the 5-year data, you can see briefly that this is the control group, this is the surgical group, and this is the control group, those of them who have had surgery over time. So that is just preliminary data, and this is a spread of the weight loss after 5 years. That we have some having a very modest weight loss, but also some having a great weight loss. And looking at this way, we can see how you have the scale there, 20 kilograms. And you see how they rank. We have none who have gained weight over 5 years. And these are the controls. These have had surgery later, but these are the ones who are the controls. So you can see how it's... Looking at the weight loss and looking at SOS, we can look at the 20-year data of the SOS. And Eva did the trick. That is quite nice. These are adolescent data. So this is the control group. This is the operated ones of the controls, and these are the ones having gastric bypass surgery. So it's quite consistent, the results. So in summary, I would say that laparoscopic gastric bypass appears as effective in adolescents as in adults. It's not that there's something special with adolescents making it not work. Our impression is that the intervention was generally well tolerated, but you will talk more about that, Eva. Major weight loss and improvements in metabolic status and quality of life can be achieved, that's for sure. Long-term follow-up and analysis of subgroups are needed before general recommendations. That's what I would like to conclude in this. So with that, I will just pass it over to Kajsa to continue.
Yes, before I start to present my figures and numbers, I just want to show you what what an adolescent girl said to me in one of the most recent pre-op evaluations I did. I think it's important sometimes to go back to the adolescents and hear what do they expect from surgery, what do they hope to get out from surgery. And this girl told me that she wanted social situations to be easier. She would be more accepted by others, and she hoped that her self-esteem would be improved. So more or less, she wanted the relationship to others to be better and her relationship with herself to become better. So, but what kind of adolescents do we meet before bariatric surgery? Do they have an average mental health compared to other teenagers? And the quick answer is no. They have a lot more problems than other teenagers. They have elevated levels of depressive symptoms, higher levels of anxiety. They are angrier than other teenagers. 1 out of 5 have a very low self-concept. And 41% had been under treatment in a pediatric psychiatric unit before entering the study. And this can be compared to 15% of Swedish children and adolescents having contact with a psychiatric unit once or more while growing up. Point prevalence numbers for depression in Swedish adolescents is between 5 and 8%. So this is much higher than expected, but it's in line with when you compare to adults seeking weight loss surgery. So, but after surgery, we did the first follow-up 4 months after surgery, and we saw significant improvements in depressive symptoms, anxiety, and self-concept. And we did not only see improvements, but we saw that they were elevated before surgery, and they came down to average levels of mental health problems just in 4 months. But the improvements were not equally distributed. Some adolescents improved very much in just 4 months. There were unchanged adolescents. Some doesn't have mental health problems, and then you can't improve them. But we saw that 16% were impaired. And then we tried to compare baseline data between the impaired adolescents and the unchanged and improved adolescents, and we couldn't see any differences between the groups. So you have to follow up everyone to catch the adverse cases. Now we're about to publish 2-year outcome data. We have followed up at 1 year post-surgery and 2 years post-surgery, and we have found significant improvements in depressive symptoms, anxiety symptoms, anger symptoms, self-concept and self-esteem is improved, mood is improved, and obesity-related problems are improved. The only 2 aspects that haven't improved after surgery is disruptive behavior and activation, which is a sub-scale of the mood scale. So we see large improvements after surgery. The improvements take place during the first year after surgery, and this is what you see in all studies of both adolescents and adults. And in AMOS, the second year was mainly characterized by stabilization. In some studies, you find a small decline during the second year, but we do not find any differences between 1 year follow-up and 2 year follow-up. And again, depressive symptoms, anxiety symptoms, anger, and self-concepts are at average levels 2 years after surgery when you compare our adolescents to norm populations. So after 2 years, as a group, they don't have more mental health problems than other adolescents. But we don't see the same outcome in every adolescent. So I'm not supposed to talk about a change in BMI, but this is the blue line is the mean trend for the whole group, and the gray lines are all individual cases that have undergone surgery. And as you can see, there is a quite uniform trend. There is just one outlier that has almost a flat line, but everyone else have the same trend. So, but when you look at mental health outcome, this is for depression. You can see that the picture is not so consistent. So yes, there is a general trend. This is a significant reduction of depressive symptoms, and a majority have a reduction. But as you can see, there are some cases that have very high depressive symptoms 2 years after surgery, and some are impaired when it comes to depressive symptoms. So many of our adolescents hope for an improved self-esteem, improved self-concept, and can we tell them that they will have an improved self-concept? Yes, our best guess is yes, as most have an improved self-concept, and this corresponds to a moderate effect size. But there are some adolescents that are not doing well, and we have to talk to our adolescents about other means to improve your self-esteem, more than just losing weight. We also had a specific measure of obesity-related problems, OP14, and obesity-related problems were significantly reduced 2 years after gastric bypass. And this corresponds to a large effect size. Before surgery, the mean value of the adolescents were in the moderate impairment, corresponded to a moderate impairment, and 2 years after surgery, they were in the mild impairment category, and that is the lowest impairment, so you can't be anything but mild. You can't be anything less than mildly impaired by your weight and body shape. And I think this is an important thing to point out, because a lot of adolescents, they come back at the 2-year follow-up and they complain about their excess skin, and they say, you have taken me out of the frying pan and put me into the fire by doing surgery. But if you look at the mean values of the whole group, they are less impaired in social situations due to their weight or body shape. So, and that's it. I think it's good to have in mind. So a lot of things look very good when you look at it 2 years after surgery, but there are some things to be worried about. We have 13% of the adolescents returning for the 2-year follow-up that have depressive symptoms in the severe range, and in a recent study in adults, it was just 0.5%. If you use the cutoff score for clinical depressive symptoms, where you're thought to have depressive symptoms that affect your daily life, we have 19% of adolescents 2 years after surgery. And there is this connection between an increased risk of suicide after bariatric surgery, and there is a strong connection between suicide and depressive symptoms. So I think we really need to take good care of these adolescents. Mood is still below age-matched norms, and if you compare the adolescents in the AMOS study to the adults in the SOS study, our adolescents are at the same mood level after surgery as the adults are before surgery. So there's something about mood that isn't really good in our adolescents. The pattern of improvement in adolescents mirror the improvements seen in adults. You have the reduction during the first year, and then it's leveling off. But I think that from a psychosocial perspective, we must regard adolescents as more vulnerable than middle-aged adults.